Well, hello, and welcome back to the Determinants of Health. In this presentation, we'll go over the basics of the Canadian healthcare system, and I apologize if this ends up being a lecture about the minutiae of policy and of law and things like that, but I think it's important that every Canadian understands our system. We talk a lot about it, we brag about it, sometimes inappropriately. The rest of the world tends to compare their systems to our systems, so it's incumbent upon us to understand the details of our system as best we can. We spend a lot of time comparing ourselves to the USA, or more accurately, the Americans spend a lot of time comparing their healthcare system to ours, mostly because we are very close nations, and they are presently undergoing a fairly upheaving situation, trying to formulate a version of Medicare for themselves. So it's important to spend a moment to compare the things that we can compare, the numbers, the outcomes, the costs, and so forth. We do know that the Americans spend more on healthcare than we do, in terms of both a percentage of their overall wealth, their GDP, and in terms of expenditures per capita, per person on healthcare. And yet, life expectancy is longer in Canada, on average. So if we accept that life expectancy is a measurement of a good health outcome, then it seems that we get a better bang for our buck here in Canada. Similarly, infant mortality is lower in Canada, so maybe our health expenditures are being more efficiently applied. The United States is one of the only wealthy nations. We call these OECD nations, the Organization of Economic Cooperation and Development, the rich nations of the world. Among OECD nations, the USA is one of the only ones to lack some kind of universal health care. With the advent of so-called Obamacare, that changed somewhat, and we'll see what form Obamacare, or the Affordable Care Act, takes on in coming years under the new presidential administration. However, despite our healthcare system perhaps being a tad more economically efficient, the systems in both countries are rising in cost. In fact, they're rising faster than inflation would dictate. So what is Medicare? Medicare is the unofficial name for a publicly funded healthcare. Right? It's a kind of socialized medicine where the public, the government, pays for much of everybody's healthcare system. So in Canada, the father of Medicare, supposedly, is this man, Tommy Douglas. Tommy Douglas was the Premier of Saskatchewan, and he is formerly the federal leader of the New Democratic political party. It's his version of Medicare that we use. There are many different types of Medicare we could have used, and several were proposed, but it's Douglas's type that we use. And in fact, a few years ago, as a result of a CBC contest or poll, Tommy Douglas was voted the greatest Canadian of all time. He's also the grandfather of actor Kiefer Sutherland. So there's that. The Canada Health Act, which was formally adopted in 1984, even though it had some versions before then and has been updated since then, is the hallmark, is the foundation for how our healthcare system is organized. It deals with how care is financed and administered, but it doesn't deal with how it's organized at a delivery level. Okay, so it makes no provisions for dictating how many doctors you need, or which services must be funded, or how we define health, or who's in charge at the hospital level, or things like that. Just more or less who has to pay for it, and who gets paid for. We have what's called a single-payer system, which is also called a monopsonistic system, and I'll talk about that in a second, a little bit more. We need to distinguish between public and private systems too. So when we say public, we mean funded by the government, funded by taxpayers, as opposed to private, which means funded out of pocket or by private companies. Different countries use public and private a bit differently, but here in North America, public means government and private means industry or individuals. A single-payer system, the monopsonistic system, is when one force, one provider, can buy all of the goods and services for a particular market, in this case a healthcare market. So who's the single payer in Canada? It's the government. The government purchases all the services and disperses them. Which services? Doctors, nurses, medical devices, the buildings in which hospitals reside, all that stuff, right? And then disperses them accordingly to the population. As opposed to a multiple payer system like the Americans currently have, where insurance companies do the purchasing and the disbursement. And as a result of a single payer system, the costs are kept fairly homogeneous. So, the Canada Health Act essentially says that the provinces and territories are responsible for the management, organization, and delivery of healthcare. We're fond of saying that in Canada, health is a provincial matter. It's not a federal matter. And this comes out of the Canada Health Act. The federal bodies, for example, Health Canada, they set up the administering policies and principles. So they collect data, for example, on our infant mortality rates and things like that. Or they respond to the international calls for data on our infectious diseases and things like that. Also, the federal bodies are in charge of giving service to specific groups, like our Aboriginal population, like our military, like our political bodies as well. So the provinces must satisfy 5 criteria to receive federal funding for healthcare. And those criteria are: they must have a public administration of their healthcare finances, it must be comprehensive, their care must be universal, it must be portable, and it must be accessible. So, what do we mean by public administration? We mean that the health insurance plans must be, and this is taken directly from the Canada Health Act, administered and operated on a non-profit basis by a public authority. Okay, what they're saying here is that it must be public and non-profit. It must be run by government and not to make money, but simply to offer service. Comprehensiveness talks about essentially the categories of services that must be provided. So we're saying here that this list of services must be provided. These include dental services. Now you're probably wondering, well, hey, I have to pay out of pocket to get dental care. I have to pay out of pocket to get eyeglasses and prescription drugs. That's true. But what we're talking here about services in a hospital. So if you're in a car accident and your teeth are destroyed, you will get oral surgery that's covered by the public healthcare system. If you're in a hospital and you need morphine because, again, you're in a car accident and you're in horrible pain, that'll be paid for by the healthcare system. But if you're getting these things as individuals through your walk-in clinic or through your family doctor, then it comes out of your pocket. So it's a little confusing. What we're talking about here under comprehensiveness is really care given in hospitals. Universality. What this means is this applies to everybody. Every citizen and permanent resident in Canada has access to our public health care system. We are all insured. So it excludes people who are covered under other types of legislation. For example, members of our armed forces have health care through a different legislative procedure. Same with if you're in prison. Portability relates to our ability to move through the country and not lose our health care. As I noted, health care in Canada is a provincial matter. So we have different health plans depending upon the province in which you live. In Ontario, our health plan is called the Ontario Health Information Plan, so OHIP. Health Insurance Plan, rather, I'm sorry. But imagine if you are a teenager in Newfoundland and you graduate high school and now you have to find a job. There are more jobs in BC and Alberta and Ontario than there are in Newfoundland right now. So you're probably likely looking at moving, at least temporarily, to one of these provinces. If there wasn't a portability clause or requirement in the Canada Health Act, now there's a strong disincentive against traveling to find work. That's not fair. If we live in a single nation, there should be very few barriers for us to move around. So having this portability consideration in the Canada Health Act prevents people from being segregated and relegated to staying where they are. It allows freer movement of people across the country. It allows economic growth. It allows exchange of people, of ideas, of skills. So in my opinion, portability is fairly important. So we take our plan with us as we move. If you live in Quebec right now and you come to Ottawa to get health care, you've probably noticed that there are forms you have to fill out to make sure that the care that you give here is billed to the health insurance plan in Quebec. Accessibility. Well, this means that there should be no barriers to getting care based upon these traditional determinants of health access, like age, gender, health status, or financial insecurity. This is transformative. So in most parts of the world, throughout the history of humankind, definitely these criteria were strong barriers to getting care. If you're poor, you could not afford care. Now, poor or rich, everybody has a right and the possibility of getting care if you are ill. Health status is an important one. So in privatized systems, it's very difficult to get insurance at an affordable rate if you have pre-existing conditions. If you are diabetic, for example, your cost of your drug plan will be quite high because you're expected to actually use a lot of those services. Whereas in Canada, regardless of your pre-existing condition state, you have the same access to care as everybody else. So what's a two-tiered system? You've probably heard this term before. So a two-tier system is essentially saying that we have one tier that is socialized, Medicare, free, paid for by government, and another tier that is paid for out of pocket with the private industry. Why would you want this? Well, currently, let's say you really need to have hip surgery done. We have a fairly long waiting list for that in Canada, probably in the order of months, because hip pain, hip dysfunction isn't life-threatening. You can probably wait. It's unpleasant, it's inconvenient, but you'd have to wait because we don't have enough operating rooms and surgeons who are available to do that surgery for you, depending on where you live. Now, in a two-tiered system, you could say, well, I have money. I'm willing to pay out of pocket to get that surgery right now, so I'll do that. Doesn't hurt anybody. These other people can still wait in line. I'm just going to go and pay and get mine done. Now the problem there is you have a risk of removing social investment from the socialized system. Suddenly the second tier system, the private system, gets better care, gets better doctors, gets the richer people going there to find care, etc. So historically, in two-tiered systems, we've seen a sucking of resources and of prestige out of the socialized tier into the second tier. On the other hand, there's a moral argument to be made that if you have the resources, why shouldn't you be allowed to pay for care that's not unethical? And also, we might need this second-tier system to make the system affordable. So that's one of the debates happening all the time in Canada around our financing is it appropriate that we just have a one-tier system and maybe we need to have a second-tier system? A larger ethical concern is a private clinic might contravene the accessibility criterion of the Canada Health Act. How? Well, if we're saying that financial status should not be a barrier to accessing care, and suddenly there's a clinic over there that only gives service if you have money, we're saying that in that clinic, poor people don't have access. It's not saying that poor people don't have access anywhere, just in that clinic. So that clinic would violate the Canada Health Act's accessibility criterion. That's the legal, ethical discussion. Do we have examples of a two-tier system here in Canada? Even though we say overtly that we don't want or have a second-tier system, we do have examples of it. For example, assisted reproduction clinics. So in most provinces, assisted reproduction is not covered under our public healthcare system. That is a separate ethical argument. The argument there is that is reproduction a luxury or a right? If it's a luxury, like plastic surgery to make yourself look better, then the public shouldn't have to pay for it. On the other hand, if it's a right, like being able to walk without pain, or being able to live, or being able to see properly, then the public should be paying for it. So that's an ethical discussion to be had as well. So as a result, fertility clinics in Canada are privatized. You pay out of pocket to have access to those services. Sometimes provinces will cover some aspects of fertility services. For example, if you're infertile due to a disease that wasn't your fault, it was the result of a medical complication, then there are provisions for paying for care like that. But again, we have this further ethical dilemma that maybe the existence of an out-of-pocket fertility clinic contravenes the accessibility criterion of the Canada Health Act. How? Think about this. Amongst poor people, let's say that again, amongst infertile people, only the rich can afford to reproduce. Is that ethical? Or we're saying that only heterosexual people can reproduce and have families now. Because if you're of a same-sex couple, you need in vitro fertilization services or other kinds of fertility services for you to be able to make a family. So does this discriminate against same-sex people? I don't know. It's a discussion that you might be wanting to have with your friends or to build a career around if you want to go into law or bioethics. How are doctors paid? In a number of ways. There are three that I will draw your attention to: fee-for-service, salary, and capitation. So in Ontario, we have OHIP, the Ontario Health Insurance Plan. That's the name of our Medicare system in this province. We employ mostly a fee-for-service system. What's that? Well, that's when doctors bill for every procedure they perform. So if they see one patient and do 3 procedures, or 3 patients and do 1 procedure each, that's the same, more or less the same bill. That's different from a salary system where you get a set amount of money, a flat salary, regardless of how many procedures or patients you see. And it's different from a capitation system. So a capitation system is when you're paid by the number of patients that you see. Hopefully you can see the pros and cons of these 3 systems from an economics incentives and disincentives perspective. For example, a fee-for-service system has a strong incentive to do a lot for your patients. On the other hand, maybe you'll do too much. A capitation system has a strong incentive to see as many patients as possible. On the other hand, maybe you're not giving those patients sufficient attention. A salary system has a strong incentive to spend a lot of time and intensity with a handful of patients, so they get very good care. On the other hand, maybe you're not seeing enough patients. So there are pros and cons at play here. There are some clinics that prefer salary systems, for example, for special needs patients. For example, addicts or homeless individuals who need a lot of care to keep them off the street, to keep them out of the criminal justice system, to keep them out of the ERs. So for them, it makes more sense to have doctors on salary who aren't worried about seeing lots of patients, doing a lot of procedures, just making sure that a set number of individuals are well taken care of. I believe that the most common kind of reimbursement in Ontario is the fee-for-service system. So, how does the OHIP system work? If you live in Ontario for at least 153 days out of the year, and you have your principal home here, then you have access to OHIP. Pretty straightforward. In Ontario, you can go to any doctor you want, anytime you want, so long as that doctor is accepting you as a patient. This may seem like a no-brainer to you, but in most parts of the world, that's not the case. In most parts of the world, you have a choice of just one doctor that you're allowed to go to. And that reduces abuse of the system. But we believe in choice here, so you can see whatever doctor you want. The OHIP process covers everything from seeing your family doctor, for vaccinations, for advice, for counseling, for treatment, to going to the ER, or a walk-in clinic, or a hospital stay. It does not include, as we've discussed, drug care, like prescription drugs. It does not include dental care, unless it's an emergency. It does not include eyeglasses. So there's some pretty expensive things that you're still paying out of pocket. It has very limited coverage for things like physiotherapy or occupational therapy or chiropractic services or massage. So there are opportunities here for expanding the scope of what we consider to be appropriate health insurance. If you travel to other countries and get into an emergency, OHIP will also reimburse you to a certain extent. So let's talk a little bit about the bodies, the organizations, the groups that are in charge of licensing and managing doctors in Canada. There's something called the Royal College of Physicians and Surgeons, and they were founded in 1929 by Parliament, and they oversee the medical education of physicians. They don't give the licenses out, but what they do is they go through and set the standards for what constitutes an appropriately well-trained physician in each given discipline. So they review the education programs, and they require physicians to maintain their competency throughout their careers, which is why doctors get CME credits, continuing medical education credits. The Medical Council of Canada is charged with assessing medical candidates, so it evaluates them through the testing process. They're the ones who give the licenses. They maintain the registry of physicians who are licensed to practice in Canada. In Ontario, we have something called the College of Physicians and Surgeons of Ontario. And this is the group that issues the certificates of registration to allow physicians to practice legally in Ontario. They also investigate the complaints against doctors, because every professional is susceptible to complaints by the people that they serve, and this group will also met out the discipline for those physicians they have found to be in violation of their codes of conduct. The Canadian Medical Association is more or less a lobbying body for physicians. They publish a journal called the Canadian Medical Association Journal, one of the leading medical peer-reviewed journals in Canada. And they also help doctors invest their money for retirement, because doctors are not technically employees of the government, therefore don't have a retirement pension plan or other kinds of opportunities that most employees would get. The Canadian healthcare system is actually fairly expensive. It costs us more than 10% of our gross domestic product, or GDP, every year, and that's a lot. These are some old numbers. Here I've got the system costing over $5,000 per person. It's probably up to $6,000 by now, or not beyond. And I think we spend just under $200 billion per year on health. A lot of money. The biggest chunk of that money goes directly to hospitals, and most of our outgo at a per capita basis is for the elderly. So we tend to save up our healthcare needs until we are quite old. We're actually, in many ways, the second most expensive system in the world, depending on how you measure it. If you think about the provincial budget as a whole, about 15% of our yearly budget goes towards education, as it should, in my opinion. But healthcare accounts for about half. So between health and education, we're dealing with 65% of our total budget. Doesn't leave a whole lot left over. As our population ages, think about what this means. As demand for healthcare increases with an aging population, which already, by the way, dictates most of our healthcare costs, we're going to have an increasing demand on our healthcare resources and infrastructure. So this proportion is expected to increase. What do those particular expenses, these 46% of the provincial budget, does it not include? It doesn't include individual spending. It doesn't include how much each of us spends out of pocket on our prescription drugs, on the other things we buy in the drugstore, like our aspirin or pain relievers. It doesn't include most of our dental and massage care, or things that we do to keep ourselves healthy. It definitely does not include gym memberships or the expense of our healthy foods. All these things that really contribute to being healthy individuals are not covered in our appreciation of healthcare costs. It doesn't include institutional spending. What's that? Well, most people have additional health insurance through their employer. That covers things like prescription drugs and eye care and enhanced hospital stay care. So the numbers I just showed you don't include that cost. It doesn't include determinant-related spending. So in this class, we know that health is not just about health care. Health is about the determinants of health: our education, our income, our behaviors. So how much health education should be incorporated in how we measure the cost of health care? Perhaps it should be, but it's not. So our system is not perfect. We have long waiting times, meaning that if you need a non-life-threatening procedure, like hip surgery, you have to wait months for it. If you need an MRI done because you hurt your shoulder and it's chronically painful, but it's not really affecting your life to a high degree, you'll wait weeks or months before getting it. Sometimes there's inappropriate overuse of the system. Think about this. According to our system, you can go see your family doctor, go to a walk-in clinic, and go to the ER on the same day for the same complaint if you don't like the answers you're given. Maybe you've got a pain in your shoulder because you slept funny on it, but nothing's actually wrong with you, but you're one of those people who just think something's wrong all the time. And you see your family doctor, and she says, "You're fine, go home, it'll be gone in a week." But you're not happy, so you go to the walk-in clinic, and they say, "You're fine, go home, it'll be done in a week." And you go to the ER, like, "Oh, please, go away, go home, you're taking up space." So 3 visits in one day, you have just consumed thousands of dollars worth of healthcare resources for something that's really not that serious. So with more flexibility and generosity in our system comes potential for inappropriate overuse. Doctors in this country are paid better than in other countries, but not as well as in countries like the USA. As a result, we do have an issue with doctors that are being trained here but end up working in the USA where they can make more money. So how is that a good investment of our healthcare resource development dollars? We're putting people through medical school here, costing us $1 million for each doctor we graduate, and yet they don't give service to Canadians when they graduate. So that's a problem. Our system is quite expensive, amongst the most expensive in the world. And we don't fund and cannot fund all procedures. Some things we have deemed to be just too expensive to fund. So, let's summarize. The Canadian healthcare system is a single-tier system. Well, a mostly single-tier system. There are some exceptions. It's a single-payer Medicare system, and the government is a single payer. We have this thing called the Canada Health Act that describes how health is administered at the provincial level and funded, who pays for it. As I mentioned, the delivery of healthcare in Canada is a provincial responsibility. The federal government has different responsibilities around setting policies and collecting data. That is all. Thank you very much.